I am presenting a case of 69-year-old diabetic male with a history of TMA of left foot done in 2020-22, presented with dry gangrene of left fourth and fifth toes extending just beyond MTPs on plantar and dorsal aspect. On examination, bilateral femorals were palpable, popliteals and pedals were not palpable, no Doppler signals on the right, left PT biphasic signals and AT monophasic signals. ABI showed 0.54 on the right and 0.93 on the left. ABPUG showed dampened waveforms on the right. Wi-Fi classification suggested high risk of amputation without revascularization, and potential benefit of revascularization was also high. So we went ahead with on-table angiogram and proceed. Angiogram showed non-flow limiting stenosis of distal SFA and P1 popliteal non-flow limiting stenosis, P2 chronic total occlusion. P3 there was short segment stenosis just above the bifurcation. Peroneal was the dominant flow into the foot, forming collaterals to the ATA and PTA which were diseased. So we went ahead with popliteal atherectomy with 𝐬𝐮𝐫 device with good clearance. But post atherectomy, we found out trash into the peroneal artery, which was the only remnant supply to the foot. Using 4 French vertebral catheter and 50 ml 50 cc syringe, we aspirated the trash, post which there was good flow beyond the trash segment. Following that, we did popliteal angioplasty with TCB, paclitaxel coated. Post procedure, there were biphasic signals in DP, PT and peroneal. Pedal acceleration time was 120 milliseconds in PT area. So we went ahead with TMA of right foot. There was poor wound response after 14 days, and though the ABI showed improvement and PAT was still 120 milliseconds, there was poor wound response, so we had to take him up for repeat tibial angioplasty. This is the latest status of the wound taken on 7th December. For the popliteal and tibial disease, we had 3 treatment options. One was intravascular lithotripsy using atherectomy devices and femorodistal bypass into the distal PTA. Reasons for choosing 𝐬𝐮𝐫 atherectomy: mixed pathology of calcified and atheromatous disease, knee joint stenting difficulty, CTO lesion in P2, and to prepare bed for DCB. The possible complications were already listed, and we have encountered the embolization. Distal embolization prevention strategies: using distal filters, slow atherectomy, continuous aspiration, low profile device use, and multiple pass techniques. Take home message: atherectomy devices are effective for debulking plaque in peripheral arterial disease, but patient selection, proper planning and appropriate adjuncts are essential to maximize benefits. Thank you.